This conference will now be recorded.
Hi all, can you hear me?
Good afternoon, ma'am. I can hear you,
Good
ma'am.
afternoon. Yeah, hi. Today we would be looking at management of monochorionic twin pregnancy, the green top guideline which is updated. All right, so let's get started. So what are the objectives or what are the topics from this particular guideline which are of importance to us? Or what do we need to know? Okay, so the first thing that we are going to look at is establishing chorionicity. Then screening for genetic and structural anomalies in twins. Screening for complications specific to monochorionic twins. Management of complications and delivery. So these are the broad topics that we would be discussing today. If there are any questions or any queries, you could put up in the chat box. All right. There. Let's focus on the key changes. What has changed in the current update regarding monochorionic twin pregnancy? And we would be highlighting those changes as well. One of the most important changes is FFDNA, fetal free fetal DNA screening is now available for twins, and that has been updated in the guideline. The second thing is there are definite diagnostic classification of selective growth restriction in monochorionic twins. The third thing is that regarding the Doppler screening, which is MCA Doppler screening, which is mandatory in all twins from 20 weeks. And the fourth is the timing of birth for uncomplicated as well as complicated twin pregnancies has not changed much, but there are specific recommendations. So earlier we were seeing that there were, as per the new old guideline, it was 30% incidence of twin pregnancy, which were monochorionic. So of all the twin pregnancies, 30% were monochorionic. Now you can see in the update that there are 20% of the pregnancies that are monochorionic. This is the latest update. Okay, possibly because we have IVF ART pregnancies on the rise, and those are usually dichorionic. When we introduce more than one embryo, you usually get dichorionic twins. Then again, we need to remember that when there is 5-day blastocyst transfer, it is associated with a significantly higher rate of monozygotic twinning compared with cleavage stage day 3 transfer. And this is quite obvious to understand because when there is a blastocyst, that means the differentiation is already formed, already happening. Okay, so it is like an advanced stage in the pregnancy. Okay, as compared to the cleavage stage, the embryo. Okay, so the blastocyst is a more differentiated stage in the pregnancy, so that when it divides, it is likely to have one single placenta, isn't it? So that is why blastocyst transfer is associated with monozygotic twinning. So this is kind of self-explanatory. Okay, like we have within the first say 72 hours, if there is division of the fertilized egg, it results in dichorionic. So this is the cleavage stage, day 3 pregnancy. If it is between 4 to 8 days, then we get monochorionic, if there is cleavage. If it is between 8 to 12 or 13 days, we get, this is monochorionic, but amnion remains separate. And here we get monochorionic, monoamniotic. And more than that, we get twins that are joined, that is conjoined. Okay, so remember the early cleavage stage is capable of forming any number of um, embryos if you divide it. So this is likely to form two separate embryos, while the blastocyst stage is already forming the part which forms the placenta. Okay, so if this divides, it is going to form monochorionic diamniotic. So this is self-explanatory. It may come as which one of the following statements is true. Okay, so remember the blastocyst when divides is likely to be monochorionic diamniotic. Around 1% of monochorionic twins are monoamniotic. Okay, so that also you could remember. Let's go to the first part of the lecture, which is determining chorionicity. Now remember, when we have twin pregnancy, the first step to do is to determine the chorionicity. We want to know if it is monochorionic or it is dichorionic. That is the most important aspect of managing twin pregnancy. So what is the problem there? When you have a monochorionic twin, okay, so this would be a monochorionic twin. Okay, there is a single placenta. There are two monochorionic diamniotic. There are two babies, okay, with the umbilical cords, but the placenta is single. Okay, and which is why there is communication across the placenta of blood vessels. While when you have a dichorionic pregnancy, what happens is there is an amniotic sac, okay, and there is two separate placenta, okay. There may be placenta here and there may be placenta here, okay. So there are two separate placenta with the chorion of both the babies extending in between the two amniotic sac in this fashion. So that is why you get this sign here. This is the lambda and this is the T sign. Okay. And these two babies are independent of each other. The dichorionic babies, these babies. These are dichorionic. These are monochorionic. So these babies, dichorionic babies, are independent of each other. They have their own placenta and they are just occupying the same uterus, and that is why there may be some compromise because of this limited space. But here, the problem is that there is sharing of the blood supply, or the vasculature there is anastomosis, which is why there is complications associated with monochorionic twins. All right, so let's go ahead. So the first thing, what we need to remember is for the determination of chorionicity, it has to be done as per the new guideline. It is mentioned clearly that determination of chorionicity has to be done when twins is diagnosed. So even if you do a first trimester scan very early in pregnancy and you see that there are twins, you check if there are two separate implantation sites very early in pregnancy, okay, which are likely to be suggestive of a dichorionic implantation. Okay, but usually for women, we offer scanning between 11 to 14 weeks. So that is why 11 to 14 weeks is the time we determine the chorionicity. Okay, and again, like yesterday we saw about down screening, the CRL should be 45 to 84. So that is the time, 11 to 14 weeks, where you can even offer down screening as well as ultrasound for chorionicity. So for the estimation of the gestational age, if there is a twin which is one is CRL having CRL say 40 millimeters and the other having CRL 40 or say 45 and 50 millimeter. One is 45 and the other one is 50 millimeter. So say 45 would correspond to around 11 weeks, 2 days. Okay. Your 50 may correspond to 12 weeks. Okay. As per the software. What would you assign the gestation for this particular pregnancy? Anybody?
The largest.
You would, yes. So
The
you would
largest.
assign the gestation as 12 weeks. So you go by the larger baby because it is possible that the other baby is small because of an early onset of some growth restriction. Okay, that is why the pregnancy duration is taken by the size of the larger baby. All right. So then chorionicity should be determined at the time the twin pregnancy is detected, as I already discussed this by ultrasound. Now, there are other things that we know. What are the various tests or what are the various features that would suggest what chorionicity the twin pregnancy belongs to? First, if you do very early the scan in the first trimester, say for example at 6 weeks or 5 weeks, you may be able to see two separate placental masses. Say not 6 weeks, but maybe a little later, 7 weeks. So you may be able to see two separate placentation. Okay. However, what we must remember is that sometimes the placenta, even in monochorionic, is bilobed and appears like they are two. And we may wrongly assign the chorionicity as dichorionic. Okay, so that happens in 3% of monochorionic placenta. Okay, so it is not foolproof. Okay, as far as membrane thickness is concerned, when the thickness is less than 1.8, it is likely to be monochorionic. Okay, when the thickness is 1.8. When the thickness is more than 2, it is likely to be dichorionic. And 1.5 to 2 millimeter is inconclusive. Okay, so which is why, again, this is not extremely reliable. It is not a sure shot test. Okay. Intertwin membrane placental insertion. This we have already seen when we saw the dichorionic versus monochorionic pregnancy. So what happens here? This is a T sign. Can you see this T? There is a single placenta here. This is the placenta and this is the T sign. Okay. And this would be the lambda sign. This is the placenta and this is the lambda sign. Okay, so this sign is also quite reliable and this is the one that is usually used to assign chorionicity. Of course, when there is discordant sex, that is, you know that there is one baby is a male and the other baby is a female, that means they are different genetic. So you know that they are different pregnancies or they are dichorionic. Okay. But it does not mean that those with the same sex would be dichorionic or monochorionic. You cannot really say. Okay. Because there could be two separate female pregnancies growing together, which are dichorionic. Right? Then, so what does the RCOG recommend? The RCOG recommends that the strongest likelihood ratios were reported for a composite method involving the presence of a lambda or T sign and noting the number of placental masses identified using the first trimester scan. And using such criteria, sensitivity and specificity were greater than 95%. So which is the best test for determining chorionicity? If asked, what would you say?
Intertwined membrane insertion.
Okay.
Intertwined membrane insertion.
All right. Any other answer? Anything else? What did we just see? Yeah, okay. T sign and lambda sign, yes, is reliable, and as we mentioned earlier, that it is the commonly used method. But what does the RCOG say? That the strongest likelihood is a composite method. What is composite? It is a combination of all methods. So look at your options. If you have T sign and lambda sign, yes, maybe you can just use you can choose T sign and lambda sign as the option, provided in the options composite method is not mentioned. But if it is mentioned, choose composite. So composite includes T sign, lambda sign, as well as the number of placental masses. So it's a composite measure of all these other parameters. All right. Okay. So that is the test. Now, if you cannot be sure what the chorionicity is, if you are not sure, what would you do? Okay, so if there is uncertainty, what would you, this is a recommendation in the guideline, which is clearly mentioned, the steps. Okay, a photographic record of the ultrasound should be kept, and a second opinion should be taken. And if still there is doubt, refer to fetal medicine unit. So chorionicity determination need not always be done in a fetal medicine unit. Okay, this is important because they often ask you questions like, when would you refer to fetal medicine unit? So it is not routinely done in the fetal medicine unit. If there is uncertainty, you will take a photographic record of the ultrasound appearance and take a second opinion. If still in confusion, then you refer to fetal medicine unit. This is clear, everyone?
Yes.
Yeah? All right.
Yes, ma'am.
Next. So, okay, so that we finished the chorionicity. Now we will see screening for chromosomal anomalies. Now this you're going to tell me because we have covered this yesterday, right? So what do we do? What do we offer women with twin pregnancies? What test?
Combined test.
Excellent. So we offer
Combined test.
combined test, right? So yeah, and another thing that you should remember is that the prevalence of chromosomal abnormalities in monochorionic and dichorionic is almost the same, although it appears that monochorionic should have higher prevalence, but it is not true. So again, you can get which of the following is not true, etc. Such questions. So it is not increased in monochorionic. Okay, it is same as dichorionic. Okay, screening is offered to all as we have seen earlier. And according to the NHS screening program, we offer combined screening test. All right. Again, the gestation at which we offer is 45 to 84 millimeters CRL, which is 11 to 13 weeks, 6 days. Then, if she misses the first trimester screening, second trimester quadruple test is offered. Just like in singleton, if she misses the first trimester, you go to quadruple. If she is more than 84 millimeter, you go to quadruple. But what was the other criteria for quadruple testing in singleton? Anybody remembers? If she's more than CRL more than 84, what next would you do?
Head circumference.
Yes, and what should be the head circumference for you to offer quadruple testing?
102 mm.
102 to 101 to 172 mm. Okay, that is the range in which you can offer the quadruple test. I'm glad that you remembered this. All right, so coming to this particular chart. Okay, now this is something that is mentioned in this guideline 2024 update. However, it is not given in a grid form, so I've just put it on a grid. Okay, so yesterday we saw singleton. The combined test sensitivity is 90%, and that is a common question. Of course, in the talk articles as well as strategy, it is 90% at 3% false positive rate, so it's almost the same. 2.5% false positive rate, 90% sensitivity. This is given in the current guideline of twin pregnancy. For dichorionic diamniotic twins, the combined test sensitivity is 90% at 5% false positive rate. And for monochorionic twin, it is 90% at 10%. 1 minute. I think there is an error here. All right. Okay. So correct. What the error here is, this is, sorry. All right. This is 10. This is 5. You know why? Because monochorionic twin pregnancy is like the same genetics, right? So it is easier to get the serum markers in monochorionic twin pregnancy as compared with dichorionic twin pregnancy, because both the pregnancies are different genetics. So say for example, one of the twins is having Downs, the other twin is a different genetic makeup in dichorionic. The other twin is normal. Now say for example, the beta HCG, which is supposed to be high in Downs, that effect may be nullified by the other twin, which is likely to be having lower beta HCG, okay, as compared with the Downs baby. So you're not going to get the sensitivity that that high in a dichorionic twin, but it is 90% at 10% false positivity rate, and monochorionic it's 90% at 5% false positive rate. Quadruple test, the sensitivity is 80% in twins at 3% false positive rate is mentioned in this current guideline. But in the old talk article for singletons, it should have been more. But the talk articles are possibly because of the older studies. So it gives the rate that we had discussed yesterday, 70 to 75% at 5% false positive rate. Okay. So this is what is mentioned in the current guideline. So this particular thing, which is appearing a bit wrong here, because singleton should have had higher sensitivity, but this is an older talk, and this is given in the new 2024 guideline. Okay. So remember, combined test sensitivity is 90%, even in twins, but the false positive rate is higher. NIPT. Now this is a new change. This is new. This was not there in the older guideline. NIPT can be offered just like it is offered in singletons. When is it offered in singletons? NIPT? Anybody?
10 weeks, ma'am.
Yeah, I mean, when not okay, from 10 weeks you can offer, definitely. But what is the criteria? What is the flow chart that we discussed yesterday? Anybody? When do you offer? First thing that you offer in singleton is? What is the screening test for Downs? First screening test? Combined test. Excellent. So first is combined test. What is the next? What happens if you get high risk on combined test?
NIPT.
Offer NIPT.
Exactly. Yes, that is what I was asking you. So that's right. So similarly, in twins as well, if there is high risk on combined test, it is NIPT. Earlier, we were thinking, we were considering low risk, intermediate risk, and high risk, and the intermediate ones were offered NIPT. Now, the NHS program says low risk and high risk should be offered NIPT. If they don't want NIPT, they want a confirmatory test, then you offer a confirmatory test directly. You need to ask the patient at every step. Okay, that is what we learned yesterday. Okay, sensitivity in twins for trisomy 21 is 99%. That is very high. All right, now this is important. Let's look at screening for complications specific to monochorionic twins. What are the complications of monochorionic twins? Can anyone tell me? Various
Twins
complications for
anemia,
monochorionic. Yes.
Twins anemia polycythemia syndrome.
That's one.
Twin
TTTS,
transfusion
madam.
syndrome.
TTS.
Trap.
Yes.
And the trap.
Trap. Okay. Twin reverse artery
Trap.
perfusion. And
Selective
Uh,
growth restriction.
Selective fetal growth
SGR.
restriction.
Correct. Good.
Discordant
Fetal growth
fetal death.
restriction. Yes.
For the
Okay.
entanglement.
And discordant anomaly also you may sometimes have. Okay. So how do we screen? We are now looking at how to screen. So let's look at a flow chart, which makes it very easy for you to remember. And this is important. And they have specifically asked for, specifically given, recommendations as to the how to go about monitoring the twins. So the first thing is this. When do we offer the ultrasound? We offer ultrasound every 2 weeks from 16 weeks till delivery for twins. For monochorionic twins, not all twins, for monochorionic twins. Okay, we are just looking at monochorionic, the guideline on monochorionic. We're not looking at dichorionic. Okay, so every 2 weeks from 16 weeks till delivery. And what are the things that you need to check in the 16-week scan? In all the scans, you would check EFW, that is growth, the fetal weight, and the deepest vertical pocket in all of them. Okay? You will also check umbilical artery PI in all the scans from 16 weeks. And what now they have recommended is MCA PSV is also to be offered from 20 weeks every 2 weeks. Okay? So when you start at 16 weeks, you will do EFW, DVP, umbilical artery, PI. At 18 weeks, you will do EFW, DVP, umbilical artery, PI. At 20 weeks, you will do EFW, DVP, umbilical artery, PI, and MCA. Okay? And this is going to be continued 2 weekly. Is that clear? Clear?
Yes.
All right. Now, what we are looking at is, as you have all told me, TTTS, TRAP, and your growth restriction. So this is something, and TAPS, okay? Twin anemia polycythemia syndrome. And these are the things that you really need to monitor, these 3 things. Because TRAP is something that you see, a cardiac twin you see immediately, you know, okay? A single fetal demise, you see the baby and you know. But you need to monitor the growth, the evidence of TTTS and TAPS. So the first thing, let's look at how to monitor TTTS. I mean, how to pick up TTTS. First, initially, you are doing 2 weekly scans, right? So now, if there is a difference in the deepest vertical pocket in the amniotic sac of each twin of 4 centimeter or more, that means there are these 2 twins, okay? And for TTTS, we need a DVP in one sac of less than 2, in the other more than 8. Okay, but if it is not less than 2, say it is say 3, and the other one is 7. It does not fit the Quintero staging, isn't it? Quintero staging says less than 2, more than 8. But here the difference is 4. That means maybe later it will become less than 2, more than 8. Okay, so at this stage, you first need to monitor. Instead of 2 weekly, you then monitor weekly. Okay, can you see that box? So if there is a difference in the DVP, more than 4, 4 or more than 4, you switch to weekly scan. Then, if then you find that there is any of the Quintero stages, we will see what Quintero staging is. If you see any of the Quintero stages, the first stage of Quintero is difference in the amniotic fluid or difference in the DVP, oligo in one baby and polyhydramnioles in the other baby. So that's the first stage. So now you find out that there is less than 2 centimeter of deep vertical pocket in one baby, and the other baby is more than 8 centimeter, the deepest vertical pocket. If that is what you see now, then you can diagnose TTTS. Once you know that this is TTTS, what would you do? The next step, if asked in the exam, what is the next step? Anybody?
You refer the patient to fetal medicine unit
Hmm?
for
Refer to
possible
fetal medicine center,
application.
ma'am.
Excellent. No, not weekly scan. You will offer a referral to a fetal medicine center. That's right. Okay. So the next step is fetal medicine center here. Okay. After that, fetal medicine unit will decide whether to whether to offer her laser or not. Okay. So that is what you need to do. Then, if now let's look at how to diagnose twin anemia polycythemia syndrome. We have evidence of anemia polycythemia syndrome by increase in the MCA PSV in the baby that is anemic. Okay, what is MCA PSV? It is the velocity with which the middle cerebral artery blood flows. So if it is going at a very fast rate, the middle cerebral artery blood, that means the viscosity of blood is less, and it is likely that the hemoglobin in that particular baby is less, which is why the viscosity is less. Okay, so when you know that MCA PSV is rising, there is a possibility that that particular baby is having anemia as compared with the other baby which is going to have a lesser MCA PSV. Okay, so that tells us, and if there are no other signs of TTTS, TTTS should have oligohydramnios, polyhydramnios. TTTS should have Doppler changes, a difference in the baby weight, etc. All those things. But twin anemia polycythemia syndrome should have evidence of only anemia and polycythemia. Okay, for the diagnosis, and there is no difference in the deepest vertical pocket. No oli and poly. Okay, it is only anemia and polycythemia. Okay, so then you diagnose that as TAPS, and again you refer to fetal. So the next option, what would be your next step if that is the question? The answer would be refer to fetal medicine unit. As simple as that. Okay, so you're referring these two to fetal medicine unit. That means these initial ultrasounds are not done by the fetal medicine units. They are done by sonologists that are trained in doing twin pregnancy ultrasound. Okay, so you refer to fetal medicine unit when there is a problem. Okay, now when you suspect there is single growth restriction, single baby growth restriction, anybody can tell me when? Anybody? When do you think that there is, when would you suspect there is growth restriction?
After
When growth
16 weeks, when
discordance
we
or
are doing
greater
2 weekly interval scans, ma'am,
Yeah, so
then we'll calculate.
yeah, go on.
And the discordance is more than 20% estimated fetal weight discordance.
Okay, excellent, excellent. So earlier that was the criteria for your discordance, okay, and to diagnose as SGR. Now what they are saying is, they are saying, one second, yeah, they are saying that if the EFW discordance is more than 20%, and look at the word and, that means that's not enough that the discordance is more than 20%, and the smaller twin EFW and AC is less than 10 centile, that means the smaller twin is smaller, is like your SGA babies, small, and there is discordance of 20%, then you suspect that there is SGA or there is single growth restriction. They have given definite diagnostic criteria for FGR. What are those? Let's look at those. Okay. What is the definition? So you will suspect first when the EFW discordance, that is the percentage difference. So the larger, how will you calculate the difference? The weight of the larger baby minus weight of the smaller baby divided by the weight of the larger baby, okay, into 100, right? So this is how you calculate the discordance percentage, right? So now they are saying if it is more than 20% and the smaller baby is less than 10 centile, what you do is you do a weekly ultrasound. Just like when earlier you were suspecting PTTS by more than 4 centimeter difference in the DVP, you were doing weekly ultrasound. Now you are doing weekly ultrasound for SGR if your discordance is more than 20% and the smaller twin is less than 10 centile. So you do the weekly ultrasound. What you find? If you find this, if there is the growth restriction has reached now less than third centile, then it is single growth restriction. One of the smaller baby, the smaller twin that is less than the third centile. Okay, then it is single growth restriction. Or any two of the following. That is, difference in the EFW is 25%, less than 10 centile. Okay, and there is umbilical artery PI more than 95th centile or absent or reversal of flow. So two of the three. Okay, does this remind you of anything else which has recently come? You have to learn both the things together simultaneously to understand these things. Does it remind you of anything? Yeah, the SJ GTG, which is similar. Okay, so both the GTGs are now in sync. Okay, so this particular SGR you can diagnose when either EFW is less than third centile or any two of the following. EFW discordance of 25% or more, less than 10 centile EFW, or umbilical artery PI more than 95th centile or AREDV. Okay, so this is something that you need to remember, and maybe may not be this exam, but may not be July exam, but maybe you'll get questions on this in the next exam. Even for MRCOG part 3, may not be in the May exam, but possibly in the next exam you may get questions on this. Okay, then so this you have to refer to FMU again once you have diagnosed SGR. So they have now developed strict criteria for diagnosis of SGR. So refer to fetal medicine unit after it is diagnosed, not before. So if the EFW discordance is more than 20%, the next step is to do a weekly ultrasound. Okay, so this is what you must remember as per the new guideline. Okay, yeah, Dr. Verinder says that if discordance is more than 20%, do weekly scan. Yes, they said discordance more than 20% and the smaller baby is less than 10 centile. Do weekly scan, but confirm the diagnosis. If EFW is more than 25%, discordance is not enough because they said any two of the following, right? So if EFW is discordance of 25% with either the smaller twin being less than 10 centile or having Doppler changes. Okay, so just 25% discordance is no longer enough for the current definition. Is that clear, everybody? Yes, thank you. So this is, I just put this slide here because this is for singleton pregnancies. The new guideline, 2024 guideline, the singleton pregnancy. This is similar. Okay, I know right now you need not go through this, but remember, whenever you're studying, look at both these charts. This is there in the GTG, but this chart is not there as such in the GTG, but this we made. Okay, so then management of complications. So we have seen screening of complications. We have seen determination of chorionicity. We have seen how to screen for genetic abnormalities. Now we are going to manage complications. Okay, the first complication. Okay, so this is important, very important. Okay, so what is the incidence? Okay, or what is the proportion of TTTS amongst the monochorionic? 15 to 20% would have TTTS. Okay, then you would have your TAPS as 2% of uncomplicated monochorionic will have TAPS, 13% after treatment of fetoscopic laser ablation. TOPS is not included in the guideline, but that is another known uh, terminology, but you need not know about it's twin poly syndrome, but you need not, it is now included in stage 1 Quintero. Okay, TRAP is where there is a cardiac twin. We'll see each of these. FGR is again 20%. Discordant anomalies is 1 to 2%. Okay, let's go to TTTS. Now, what is the problem in TTTS? So the problem in TTTS, what happens is there are venous arterial communications in the placenta of the two twins. Okay, and remember, if it is arterial like this, what is going to happen? Artery is from the twin A is pushing blood this way, from the twin B is also pushing blood this way. So this is going, both are pushing towards each other. So this effect is going to be nullified. Okay, but what happens with a artery to vein anastomosis? Artery is pushing this way and vein is also going this way. So what is going to happen? Blood is going to be pushed from this twin into the placenta into the second twin. So when there are big artery vein anastomosis, you get a big difference in the in the blood volume of the two twins, and that is TTTS. But when there are minuscule small artery vein anastomosis, small ones, what happens? You get a small amount of blood flowing from one baby to the other, and in that case you get TAPS. So it doesn't cause obvious oligohydramnios and polyhydramnios, etc. It causes anemia and polycythemia, while this causes TTTS. Okay, so when there are bigger vessels communicating, it causes TTTS. When there are small, minuscule communications across the placenta of both the twins, it causes TAPS. All right. So this is the pathology for TTTS. Now, coming to the management of TTTS. Okay, you have to tell all of them. This can be one of the points that you can mention to your role players in MRCOG Part 3. Always ask your monochorionic twin pregnancies to report sudden increase in abdominal size and breathlessness. And also when you see them, ask about history of breathlessness or increase in the abdominal size. Okay, this is important for part 3 in history taking. Now, there is you must also remember that TTTS is treated with laser, but after treatment as well there is a 14%. This is something new. 14% chance of recurrent TTTS. Quintero staging we will be seeing shortly. It has to be managed. They have given specifically in a fetal medicine center with recourse to specialist expertise and treatment in something called as supra-regional centers. Again, this may be important for part 3 when you have a structured discussion. Okay, so TTTS is important. It's important to say these supra-regional centers. Okay, TTTS presenting before 26 weeks of gestation should be treated with fetoscopic laser ablation rather than amnioreduction or septostomy. So what is best is laser ablation. After 26 weeks, they say it is to be individualized. Okay. So earlier they may have mentioned that septostomy can be considered after 26 weeks. Here in the new guideline, they just say that it has to be individualized. Okay, then the evidence that fetoscopic laser ablative method should be by a serial sequential technique followed by an equatorial laser ablation that is called as Solomon technique, and this is specifically mentioned in bold letters in the new guideline. Okay, Solomon technique is what is preferred. Okay, so equatorial. So equatorial means where you have to there are those two twins, right? And there is the placenta. Okay, there are two twins having the umbilical cord, but the blood vessels may be anastomosing somewhere here. This may be this baby's placental side, and this may be that other baby's placental side. Okay, so you have to ablate the blood vessels that are at the equator, wherein there is clear-cut division between the blood vessels of the two babies, distinction of the blood vessels of the two babies. Okay, not really important for you to know, but remember that it is a Solomon technique. Okay, now after the management of TTTS, you will offer them weekly ultrasound. Okay, sorry, this is okay. You will offer them weekly ultrasound. Okay, again the same things are checked, and along with that you will now check ductus venosus Doppler velocities. Okay, so this is what is mentioned here. Then after the first 2 weeks, if she is doing fine, you can increase the frequency to, you can decrease the frequency of monitoring to every 2 weeks. Okay, but umbilical artery PI, MCA, PSV and DVP now is monitored. Okay, earlier you have been monitoring the ductus venosus also for the weekly ultrasound. After that, you know that she's doing fine, then you go back to your original method of monitoring, that is umbilical artery PI, MCA, PSV, DVP. Okay, and growth, EFW. Growth is EFW. Okay, so that is what you were doing anyway from 20 weeks. All right, and it is also mentioned that you need to look at the fetal heart after treatment of TTTS by a fetal medicine specialist, because in 11% of the cases there is structural heart disease. Okay, so that is why it is important to look at the heart. Amnioreduction, they say you offer only when there is no expertise and facilities for laser coagulation, when you are about to transfer the patient till, and the treatment is not immediately available, and when the condition is diagnosed after 26 weeks, you can consider. Okay, it's not recommended, it is considered. Okay, other options: selective termination of the pregnancy using bipolar diathermy of one of the umbilical cords using radio frequency ablation or bipolar diathermy. Now, what is this? It is usually done when the pregnancy is less than 24 weeks. That means at 24 weeks, say you find one baby which is very small and one baby that is having, this baby is tiny and this baby is big, and there is poly, okay, and there is communication. Now what happens is, because, and these are the umbilical cord, this baby and this baby. Okay, what happens here is there is a chance that because of that small baby and this big baby pumping blood into the small baby, there is a chance that the big baby may die of failure because it is taking care of the small baby as well. And this has happened very early in pregnancy. That means it is likely to be severe. Okay, so what you do is you do feticide of this baby. How you do it? By doing coagulation of the umbilical cord. Now what happens? The problem when this baby dies is that this baby is likely to bleed into this baby, and that is how this baby gets neurological impairment, and that baby gets risk of death is there in this baby, in the donor baby. But when you coagulate the cord, there is no blood flow from this baby to this baby because you have taken care of the road to the other baby. Correct? So the other baby will, that will save the donor baby from dying. So that is why when it is very early, you can do selective cord coagulation of the smaller baby, so as to prevent sudden demise of the donor baby when the smaller baby dies. Okay, so that's the thing. And understood that concept of, so if it is given that severe TTTS less than 24, option would be to do a selective termination of pregnancy. All right. This is Quintero staging. So Quintero staging stage 1 is where, as we have already seen, less than 2, more than 8. More than 8, less than 20 weeks. More than 10 is considered after 20 weeks. But the donor bladder is seen and Doppler is normal. Stage 2, bladder of the donor is not visible because there is severe oligohydramnios in the donor. Okay, and the the Doppler studies are not critically abnormal. They are not severely abnormal. Okay, so the Doppler studies are critically abnormal in stage 3. That means there is a reversal of flow, absent and diastolic flow, increase by 90, more than 95th percentile of PI. All those changes, the severe ones are, or DV Doppler changes, severe ones are critically abnormal stage 3. Ascites, pericardial pleural effusion, or scalp edema overt hydrops is stage 4. Okay, and stage 5 is when one of the baby is dead, and that is not amenable to therapy because, as we know, the other baby will die. The live baby will bleed in this dead baby, and hence the live baby is also going to be dead soon. Okay. There. Management of single growth restriction should be done at a fetal medicine center. Okay. Now we have shifted to single. We were discussing TTTS earlier. So what we have learned about TTTS is that the treatment option is, the best one is laser, Solomon technique. Amniotomy or amniocentesis can be considered after 26 weeks. And very early, where you think that the pregnancy may not be salvageable if you let it continue and the baby is very extremely growth restricted before 24 weeks, you can do selective feticide, okay, less than 24 weeks. Okay. Now, for management of single growth restriction, it is done in the fetal medicine center. For early onset, again, you can do the same thing as TTTS, that is selective reduction or fetoscopic selective reduction. Sorry, fetoscopic laser ablation can also be done if you think that this baby is likely to be salvageable. But you can have an option of selective reduction. One of the babies you can sacrifice. Okay. Ultrasound, once you have diagnosed SGR, after that, how often do you do ultrasound is individualized. Depends on how severe the SGR is. You know that before you have diagnosed SGR, if there is 20% discordant, you switch to weekly monitoring. And then you diagnose when there is 25% discordance along with less than 10 centile or umbilical artery Doppler changes. Okay, then you diagnose, and then how often you monitor is to be individualized. Okay, but what they have mentioned is that fetal growth should be at least done 2 weekly, because it doesn't make sense to monitor fetal growth too often. Okay, you have to give it time. So at least 2 weekly, and Doppler assessment at least weekly, at least. Okay, so that is what is mentioned. There are types of SGR, okay, single SGR, and this is important. So type 1 is where you can see in the first picture, there is positive flow in this. That means this is the baseline and the umbilical artery PI is always in the positive side. So there is, even in the diastole, there is some flow here, and this is systole. This is positive flow is always there. This is type 1, which is the better prognosis one. This one has absent, and this one has cyclical flow. Can you see there are absent waves here, absent flow, and this has cyclical flow. Okay, so this is your types of SGR. They have given this is taken directly from the guideline, how to deliver, when to deliver. Just like in your single FGR, your delivery between 26 to 34 weeks, 26 to 34 weeks is based on, if it is single severe SGR, is based on two things, just like singletons, DV Doppler and computerized CCTG. Okay, so computerized CTG. You don't have to remember the values of CTG, but you have to remember that that is used for decision regarding termination of pregnancy. Also, if there is static growth, that is the baby is not growing at all, you can deliver the baby. Give steroids, give magnesium sulfate and deliver the baby. Okay. Now, TAPS. Let's go to TAPS. When to deliver, I have still not touched upon. The time of delivery, we will see in the form of a chart. Okay. So management of TAPS, basically how to manage TAPS is not very clear. How to manage the anemia and polycythemia, but the options include expectant management, planned twin birth. So you'd plan, say for example, she's already reached 34 weeks and you have given her steroids. You could just deliver her, okay? Or if she's too early that you have picked up, you want to push the pregnancy a little ahead, you can give intrauterine blood transfusion, okay? It's too early, you can even consider selective feticide, okay? Or you can even consider fetoscopic laser surgery. All of this in fetal medicine center. So all of the complications of TTT, of monochorionic pregnancies would be at fetal medicine center, managed at fetal medicine center. Now, let's go to the next thing, that is single twin demise. Okay. After a single death, fetal death in a monochorionic twin, the risk of surviving twin of death is around 15%. Death is 15%. Neurological abnormality is more, 26%. Why that happens? Because of what we have seen earlier, that you have the small twin and you have the larger twin. Okay. And you have the small twin, which is, say, oligo, because it is giving blood to the bigger twin. Okay. And there is, these are the cords. So what happens here is, when, if this dies, because this is not growing at all, and this dies, you have this twin blood going here, here, into the placenta, through the communications into this baby. Because this baby is now not pumping blood, right? Because it is dead. So this baby is pumping blood here, and that blood she is losing, that baby is losing into this baby. So this baby will die of shock, basically, or even if it survives, the brain will have damage. That is what happens in single demise. So again, this has to be monitored at the fetal medicine center, okay, with multidisciplinary expertise. Because there could be brain damage, you do an MRI after 4 weeks. Regular ultrasound scans have to be continued in the surviving twin, and the surviving twin bleeds in the other twin, so can have anemia, so you have to do MCA PSV. MRI, ultrasound surveillance, MCA PSV has to be done. Okay. Now, this is important. When do you deliver these twins? Okay, let's see. So, uncomplicated dichorionic diamniotic twin pregnancy has to be delivered. We know that this has not changed as per NICE guidelines, 37 weeks. Okay, uncomplicated. Okay, again, there is a mistake here. This is monochorionic monochorionic diamniotic. What we are dealing with currently. Monochorionic twins have to be delivered at 36 weeks. Okay? This has not changed. Uncomplicated trichorionic, triamniotic or dichorionic, triamniotic triplet is still 35 weeks. Triplet pregnancy at 35 weeks. Okay? Then, if there is TTTS which is treated with laser, 36 weeks. Earlier they said 34 to 36 weeks, but here they said you monitor, if it's fine, you deliver at 36 weeks. Of course, if there is a problem, you deliver earlier, but you monitor. If the baby is doing fine, you deliver at 36 weeks. Okay? The MAMC is delivered monoamniotic monochorionic. So both the twins are in the same sac. Okay, they are not in different sacs. Both the twins are in the same sac. What can happen? Their cord can get entangled. So they are delivered early, the 32 to 34 weeks, and they are delivered by cesarean. Okay, all of these are potential questions in MRCOG part 2. If there is a single twin demise, this one says by 36 weeks, 6 days. So this is a little extended, 36 weeks, 6 days. And you know why this is? Anybody knows why that could be? Why? Okay, fine. So
Delivery.
this, yes, tell me, yes. We wait for MRI for 4 weeks, but yeah, we wait. But that is not the reason why, you can evaluate baby even after delivery. The reason here is that the maximum damage is done already at the time of the demise. Okay? Since the maximum damage is done at the time of the demise of the other twin, you cannot do anything about this pregnancy. Okay? The very fact that the pregnancy has done fine to reach 36 weeks, that means the baby is likely to be fine to reach till even 37 weeks. So you deliver by 36 weeks, 6 days, or a little later than the recommendation of monochorionic twins. Okay? This is monochorionic. Okay? So you deliver a little later than what is recommended for just uncomplicated monochorionic twin, because you know that there is nothing that you can reverse here. You at least you can stretch the pregnancy further so that you don't have to deal with a pretermer. Okay, so that is why any single twin demise you deliver at 36 weeks, by 36 weeks, 6 days. Of course, if there is problem, IUGR, if there are other things like TAPS, etc., setting in this baby, or not TAPS as such, but if there's anemia setting in this baby, then you would do a delivery early. Okay, but if it is not, the other baby is doing fine, you continue till 36 weeks, 6 days. Okay. Type 1 SGR. This is the SGR where there is positive flow in the umbilical artery. Although there is SGR, but there is positive flow. There you deliver at 34 to 35, by 34 to 35 weeks. Okay. It is not at, you deliver by 34. Don't go beyond that. That is what they mean. If there is a problem before that, yes, you deliver. But don't go beyond 34 to 35 weeks for type 1 SGR. For type 2 and 3 SGR, deliver at 32 weeks, by 32 weeks. You may have to deliver earlier, but try to stretch till at least 32 weeks. Okay? That is what it means. Now, this is another thing that they have included. For preterm birth in monochorionic twins, up to 34 weeks, 6 days, steroids to be administered. Before 34 weeks, magnesium sulfate should be given. Okay? This is added in the guideline. Monochorionic twins can have a vaginal delivery. Okay? If they are uncomplicated monochorionic twins, they can have a vaginal delivery. Of course, provided the first twin is cephalic. Okay? Any other presentation, you do cesarean. The second twin presentation is not important for twin delivery because we will either rotate the second twin if it is transverse externally or if required internal podalic version. Okay. Whether to do delayed cord clamping, evidence, there is insufficient evidence because what is mentioned is that if you delay the cord clamping and there is communication, there could be a problem for the other baby because these babies are likely to have communications across the placenta. Okay, so for monochorionic twins, whether you do a delayed cord clamping is a query. Discordant anomalies. What do you do for discordant anomalies? Again, you send them to the fetal medicine unit, you do a karyotyping, okay, and you sample both the sex. Both, normally if it is known that the baby is, the twin pregnancy is monochorionic, normally what you do, one sec. What you do in a monochorionic twin pregnancy when you are doing amniocentesis, this is the placenta, monochorionic twin pregnancy. You sample only one sac because you know that they are monochorionic. Okay, the criteria is provided you know they are monochorionic and they are concordant for fetal structure. So they are not like one fetus is having one, say, heart disease and the other heart, congenital heart anomaly, and the other fetus is normal. Then it may be possible that they are not the same genetics. In that case, you sample both the twins. So if there is discordance for the abnormalities, you sample both the sacs. Okay, and if the baby is so anomalous, you can do selective reduction by cord coagulation. You cannot use KCL. Remember that KCL cannot be used because it is injected into the one baby. Okay, it can go across the umbilical cord into the placenta, into the communications, into the other baby and kill the other baby. Okay, that is why if you want to kill this baby, you will just do cord coagulation. You will let the other baby survive. Okay, this is about discordant anomaly. The last slide, okay, the last part of the guideline, okay, is conjoined twins. So again, conjoined twins, nothing major can be done. It has to be managed at a fetal medicine center. Incidence is around 1 in 90,000, 1 in 1 lakh. This may be asked. Delivery is by cesarean section because you cannot, it will result in obstructed labor. All right. So this is about the new guideline summarized. Any questions you can ask me. Anybody, any questions? No questions? Everything is understood? All right.
Madam,
Thank you. Yeah.
Madam, if
Yes,
there
please
is a
ask.
case of more than 27 weeks with the TTTS, then what should we say in the management as there is in the guideline?
As per the guideline, you can consider amniocentesis, but again, it is preferred is your amniocentesis in amnioreduction, I mean, but the preferred is still laser, but it may not be feasible to do laser at advanced stage in pregnancy. That is why they say you can consider, see, one of these points is, and the condition is diagnosed after 26 weeks. That is why they say you can consider amnioreduction, but it is not preferred. It is like the pregnancy has gone beyond the optimally treatable period. Optimally treatable would be earlier than that. And most TTTS are diagnosed earlier. Okay, so in that case, it is and your laser. Okay.
Okay.
Yeah. This was a question in the structured discussion, no, in MRCOG part 3, the 27 weeks lady. So there you just have to say that you would refer her to fetal medicine center because she's beyond 26 weeks. Whether to consider laser or to consider other options like amnio reduction would be discussed within the fetal medicine unit, MDT. Okay, that is what you would say in the exam.
Okay, madam. Thank you.
Yeah. Okay. Any other questions? Okay, then. All right. So, good night, everyone. I'm also thinking of having a revision class or a summarizing the guideline of herpes. That is another interesting update guideline, maybe next week. Okay, would be announcing that as well in the group. All right. Thank you. Thank you for attending.
Thank you, ma'am.
Thank you.
Thank you, ma'am.